Good day, everyone. In today's presentation, we shift our attention to a facet of COVID-19 that has garnered increasing attention in recent research, lipid peroxidation as a hallmark of severity in COVID-19 patients. We will explore how understanding lipid peroxidation can provide valuable insights into the severity of COVID-19 cases. But before we delve into the journal article, here's the content outline, the introduction, methodology, results and discussion, conclusion, and finally our group analysis and critique. The emergence of severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 in December 2019 has led to the global pandemic of COVID-19. While most cases exhibit mild or no symptoms, approximately 20% develop severe illness necessitating hospitalization, often characterized by high fever, pneumonia, and acute respiratory distress symptoms, or the ARDS. The pathogenesis of COVID-19 involves imbalanced cytokine responses, endothelial inflammatory reactions, and vascular thrombosis. Oxidative stress, a response to infections, is implicated in viral pathogenesis by disrupting the redox balance of cells and inducing massive cell death. Studies have shown that various viruses, including respiratory syncytial virus or the RSV and influenza, can disrupt the redox reaction within cells. RSV induces reactive oxygen species production, leading to pro-inflammatory cytokines and innate immunity, and it increases lipid peroxidation and decreases glutathione. Similarly, influenza infection results in excessive ROS production in different tissue, inducing apoptosis and cytotoxicity in alveolar epithelial cells. Notably, influenza facilitates the activation of protective enzymes against oxidative injury. Despite these insights, limited research has explored the role of oxidative stress in COVID-19 pathogenesis. Now, this study aims to comprehensively evaluate the oxidative stress profile, including antioxidant enzymes, total antioxidant capacity, and oxidative cell damage in plasma samples from a prospective cohort of COVID-19 patients. By focusing on lipid peroxidation, a biological free radical chain reaction, the research seeks to elucidate the potential role of oxidative stress in diagnosing and determining the severity of COVID-19. The study involved 108 adult COVID-19 patients admitted to the Hospital Clínico Universitario de Valladolid, Spain, whose diagnosis was confirmed by polymerase chain reaction or the PCR on nasopharyngeal swabs. Inclusion criteria included other acute diseases, infections, or chronic terminal illness. Additionally, 28 age and gender matched healthy volunteers were recruited as controls. The patients were categorized into three groups: controls, mild or moderate COVID-19 patients, and critical COVID-19 patients. Within the COVID-19 group, subgroups were identified based on mortality, intubated or death patients, and non-intubated or death patients, or the mild. Biological samples, specifically plasma, were collected at 9 a.m. after their first night of hospital admission. Blood was collected in 3.2% sodium citrate tubes, centrifuged, and stored at negative 80 degrees Celsius until used. The study assessed antioxidant enzymes levels, including superoxide dismutase and catalase activity using colorimetric assay kit. The superoxide dismutase activity assessed by reducing oxygen to form a colored product. Catalase activity determined by decomposing hydrogen peroxide and measuring the yellowish complex. Total antioxidant capacity was determined through FRAP, or the ferric reducing antioxidant power, and the ABTS assays, which are based on iron reduction and colorimetric tests respectively. Oxidative cell damage levels were measured by evaluating DNA oxidized guanosine and lipid peroxidation products. These included the analysis of malondialdehyde for hydroxynonenal and protein carbonyl as an index of lipid peroxidation. And lastly, statistical analysis employed the Mann-Whitney test for group differences, Kruskal-Wallis test for variations across COVID-19 severity, and the Cox multivariable logistic regression to explore the association between the lipid peroxidation and intubation or death risk. Kaplan-Meier curves and Lagrange tests were also used to assess the probability of intubation or death up to day 28. The significance level was set at P less than 0.05 and the IBM SPSS 22.0 software was utilized for data analysis.
136 patients were involved in the study. Their ages were similar to each other. COVID 19 and non COVID 19 patients shared common comorbidities such as diabetes, lung diseases, and coronary diseases. Comorbidity is the occurrence of two diseases at the same time. Similar comorbidities exposes the study's patients to the same symptoms and same high risk of contracting disease and more severe COVID 19 symptoms. Despite these similarities, there were differences in the plasma test results of these patients. COVID 19 patients had high levels of C reactive protein and D dimers. C reactive protein levels rise in times of inflammation or the recruitment of various inflammatory sites to a site of infection. D dimers, however, are released when a blood clot breaks down, and higher levels indicate more dissolving of these clots. COVID 19 patients also exhibited a lower lymphocyte count, a lower platelet count, a lower leukocyte count, and high neutrophil levels. Neutrophils are among the first responders of inflammatory cells, attacking pathogens like bacteria, fungi, and viruses. COVID 19 patients also had longer hospital stays and recorded mortalities. As for non COVID 19 patients, no deaths were recorded. Now I move on to the results of the determination of oxidative stress levels from tests done on the plasma samples. COVID 19 patients were found to have higher levels of oxidative cell damage, which is indicated by higher levels of 8-OHDG. Oxidative cell damage occurs when reactive oxygen species occur in excess and react with various cellular components, causing cellular damage. One way reactive oxygen species cause damage is through lipid peroxidation, where free radicals take an electron from lipids. This electron usually comes from double bonds or unsaturated fatty acids. COVID 19 patients exhibited higher levels of lipid peroxidation, evidenced by higher concentrations of lipid peroxidation products MNA and HNE. In response to oxidative stress, antioxidants act on free radicals by donating an electron and decreasing their reactivity. So it makes sense that COVID 19 patients had higher levels of antioxidant enzymes, evidenced by greater levels of SOD and catalyzed enzyme activity. Despite this, they still had lower total antioxidant capacity versus non COVID 19 patients, which is evidenced by ABTS and FRAP assay. Finally, lipid peroxidation levels were identified by COX multivariate regression analysis as an independent risk factor for death and intubation in COVID 19 cases. Furthermore, higher lipid peroxidation levels were observed in intubated/dead COVID 19 patients compared to non COVID 19 patients. Finally, lipid peroxidation levels above 1,948.17 micrometers died or incubated 8.4 days earlier on average compared to those with lower lipid peroxidation levels. So, what can we take away from this? SARS-CoV stimulates the production of reactive oxygen species. Normally, angiotensin II produces reactive oxygen species by stimulating NADPH oxidase. Angiotensin converting enzyme 2 or ACE2 usually prevents this by degrading angiotensin 2 to angiotensins 1 to 7. However, with the onset of COVID 19, ACE2 is bound to SARS-CoV-2, causing it to lose this functionality. Without these controls, reactive oxygen species production remains uncontrolled. Free radicals undergo lipid peroxidation, protein carbonylation, and DNA oxidation. Lipid peroxidation involves the oxidation of unsaturated fatty acids or other lipids. From this, MDA can be synthesized, which may lead to ferroptosis or regulated cell death from lipid peroxidation. This then leads to damage and loss of function in cell membranes. During ferroptosis, polyunsaturated fatty acids are accumulated. These fatty acids can then be used during lipid peroxidation. This then creates an endless cycle of oxidative stress and cell damage, which is why lipid peroxidation is often associated with diseases like cancer and Alzheimer's. To conclude this discussion, This study found a correlation between lipid peroxidation and the severity of COVID 19 symptoms. This is supported by a previous study that found lipid peroxidation in COVID 19 patients. However, there were no differences in severity observed, which may be due to a small sample size.
So, for our conclusion and analysis, in this study, the important role of oxidative stress in COVID 19 was highlighted. It was seen that higher lipid peroxidation levels are independently associated to a higher risk of 28-day intubation or death. The conclusion of this study provides potential clinical relevance. With this information, contribution to the development of prognostic markers or therapeutic strategies for COVID 19 patients may be one of its strengths. The study utilizes a comprehensive approach by evaluating various aspects of oxidative stress, including antioxidant enzymes, overall antioxidant capacity, and oxidative cell damage. This multifaceted analysis provides a more comprehensive picture of the oxidative stress profile in COVID 19 patients. Moreover, the discussion appropriately emphasizes the clinical implications of the findings, particularly the potential role of lipid peroxidation in predicting the severity and prognosis of COVID 19. Therefore, making call for clinical trials to explore antioxidant treatments align with the translational potential of the research. On the other hand, the oxidative stress biomarkers were measured only at the time of the first hospital admission. This limits the study to have that specific time frame when the disease was acquired. Including a longitudinal analysis with multiple time points could provide a more dynamic understanding of oxidative stress progression throughout the course of the disease. The study also has a control group size that is relatively small compared to the patient group. Having a larger control group could strengthen the study's findings and improve the generalizability of the results. A larger control group would strengthen the study's validity and allow for more robust comparisons. To add, the discussion proposes the need for further prospective follow up studies with serial sampling to validate the results. It would be helpful to provide more details on the specific aspects that should be investigated in these follow up studies and how they could address current limitations. Moreover, the study does not provide information on the demographic characteristics of the study participants, like age, gender, or comorbidities. Understanding these factors is essential for generalizability and may help identify potential confounding variables. Furthermore, the authors appropriately employed statistical methods to analyze the data. However, the paper could benefit from a more detailed explanation of the rationale behind selecting specific variables in the regression model, enhancing transparency for the readers unfamiliar with the field. This article provides a thorough exploration of the study findings, providing mechanistic insights and clinical implications. Addressing the mentioned areas for consideration would further enhance the study's impact and applicability. So that is all for our journal article review. Again, this is Group 6 for lipid peroxidation as a hallmark of severity in COVID 19 patients.